Thank you very much, and thank you for the invitation. I'm honored to be here, and I'm so happy to see all the progress that's being made, and I've been in practice a long time, and it's nice to see we're finally getting somewhere. And you've already heard this part, that lung cancer is the most common cancer and kills more people, affects more people than breast, prostate, and colorectal combined. And we know that overall the survival has been poor and really has not changed over the past 20 years. That might be a little old now. I think we've made some progress. And that about 70% of lung cancers are attributable to smoking. We know that a quarter of our patients are lifelong non-smokers, and so lung cancer screening, we all think it's going to be the best thing, and I think it's very important, but it's not going to pick up the non-smokers, and so that's a problem. So this all goes back to the the National Lung Cancer Screening Trial, which really provided us with level 1 or high-level evidence that screening works to reduce lung cancer mortality. And this was a huge trial, over 50,000 participants who were randomized to either chest X-ray or low-dose CT. And after 6 years of follow-up, there was a 20% reduction in lung cancer mortality in the screened group. And that's a huge number. It may not seem like a huge number, but that is a huge number. In breast cancer trials, that number is 3 or 4%. So we're way ahead. The other interesting finding was that there was a 7% reduction in all-cause mortality. That means like people were dying less of other things, not just lung cancer, and that was probably attributable to smoking cessation. So smoking cessation was an important part of this program. And when we try to justify our existence to the people that pay for these things, the number needed to screen to save one lung cancer death in this trial was 320. So 320 individuals screened saves one lung cancer death. In colon cancer, it's 600 colonoscopies. In mammography, I'm not sure the number, but it's like 1,000. This is the lowest number needed to screen to save one individual. So what have we done so far? Well, Cancer Care Ontario has been criticized for being a little slow to get going. The impetus to start getting going was in 2010. There was this big meeting in Oxford about prevention and screening, and the preliminary results of the NLST were presented at that meeting, and the head of prevention and screening, Dr. Linda Rabenek, was at that meeting, and some other folks from Cancer Care Ontario, and they said, oh, we better get going. And basically the consensus on that meeting was, this is high-level evidence, it's never going to get any better than this. There were a number of other trials that were ongoing, but they were much, much smaller, and this was all the evidence they needed. So although we kind of criticized Cancer Care Ontario for being a little slow off the mark, they actually knew how to try to get money out of the government. And the first thing they did was to commission the Program in Evidence-Based Care to do a guideline. And they'd found in the past that when they did this and there was an evidence-based guideline, then the Ministry of Health was more likely to listen. So they did a guideline, and of course the guideline said, screening is good and should be done. They then commissioned a health technology assessment to figure out how much it was going to cost and what was the best strategy and so on. And now we're at the pilot stage, so we're now developing these pilots. And so we have these different phases, and we kind of put together idea of what the program should be. We developed all our policies and so on, and then we put out requests for proposals for pilot sites. Now, why pilots and not just roll it out to everybody? Because we had no idea, and you may think it's easy, everybody's going to come and get screened, but we really have no idea if it's going to work, if people will come, if they'll come back, will it really work? How much is it going to cost? Do we have to buy new CT screeners? So there are a lot of unanswered questions. Nobody is questioning the value of this approach of lung cancer screening. So when people say, oh, Cancer Care Ontario is just trying to stall, they're not. They just, there's a lot of questions that we're hoping to answer with our pilots. So what is involved with a lung cancer screening program? Well, the key components are to screen those who are at the highest risk. So it's a little different than breast cancer, where they can send out a letter to every woman in the province over a certain age and say, okay, you need to come for mammography, or every person in the province over 50 and say you need to come for a colonoscopy. Not everybody is at risk for getting lung cancer. So we want to identify those at high risk. We know that smoking cessation is an important component of this program, and so we want that to be part of the program. We don't want to cause trouble by screening people, because we know that CT scans nowadays show a lot of stuff that isn't lung cancer. So we don't want people going and having an operation for something that isn't lung cancer. We want to make sure they come back for follow-up. So if they have a little nodule found, do they come back for another scan in an appropriate time period? Because again, we have all these little nodules, and most of them aren't cancer. 90% of them aren't cancer. And so we want to make sure that if we find a little one that doesn't look too worrisome, that we bring that person back at a suitable interval and make sure that it isn't growing. And lastly, we want to be very clear about our communication with the patient. So, you know, people come for a CT scan, they hear that there's something on their CT scan, and, you know, what do they think? Oh, I've got lung cancer and I'm going to die. We need to communicate very clearly with the individuals who are coming for screening what the test is about, what the possible outcomes of the test are, when we get the test results, what they mean, when you need to come back, what's going to happen next. So I don't know what it's like in other provinces, but in Ontario, you know, if you're a woman and you get your mammogram, you know, you're waiting the mail and you get a letter back in a few weeks, and then it says, oh, you need to come back. And you're like, oh my God, now what? And, you know, lots of times it's nothing. But I think that's terrible that we have to wait, and we don't know what the next step is going to be. So that's part of my strategy in this program, is to make sure that when the individual leaves the screening appointment where they have their CT, they know what the next step is. So who to screen? Well, we want to identify those individuals who are most likely to develop lung cancer and not screen those people who aren't likely to develop lung cancer. And, you know, why? Well, we don't want to give a scan to a bunch of people who are never going to get lung cancer, because that's unnecessary radiation. Now, we're using low-dose scans, so low radiation dose, but nonetheless, it's radiation. And if you're 55 years old and you come for a CT scan every year and you live to 80, that's a lot of scans. So if you're not one of those high-risk individuals, we don't want to expose you to that. Similarly, we don't want to expose you to unnecessary biopsies and so on. Our basic eligibility criteria, so there were the NLST criteria, which were age 55 to 74. You had to have had over 30 pack years of smoking, and if you had quit, you'd had to have quit within the last 15 years, and those were pretty good. But we looked at a different model, which was the Tamamagi risk prediction model, which predicts an individual's risk of developing lung cancer over a 6-year period. And we found that the risk assessment actually was more sensitive at picking up people who are likely to develop lung cancer, and more specific, so ruled out those people who weren't so likely. And so that's what we've decided to use, is this risk prediction model. So what we found was that when we chose a risk cutoff of greater than or equal to 2%, so you think, well, that's pretty low. But we looked at that, and that would be roughly equivalent to the risk that was used in the NLST, and we actually found that the number needed to screen is actually 200. So we could screen fewer people and pick up more lung cancers than the strategy that they used in the NLST. So that's why we've chosen to use this risk prediction model. So we've chosen 3 pilot sites, and as I said, we went with pilot sites to kind of try to get the bugs worked out before we rolled it out across the province. There were certain criteria for the pilot sites to be eligible, and I'll show you those in a moment. But basically, the eligible sites had to have a level 1 thoracic surgery center, and in Ontario and in many provinces, actually thoracic surgery is regionalized to centers where there are more than one thoracic surgeon and so on. And they had to have an on-site lung diagnostic assessment program. So again, we've regionalized lung cancer assessment to try to expedite the diagnosis and staging and treatment of individuals who are identified with lung cancer. So the pilot sites had to be a level 1 thoracic center and had to have an on-site lung DAP. And then we're expected to launch next April to actually start screening. And so the sites that were chosen were, we had 10 sites apply, so we had very good uptake in terms of people's interest and excellent proposals from everyone. So it was very difficult to choose. And we had a panel to choose that was a thoracic surgeon from outside Ontario, a radiologist from outside Ontario, and a respirologist from outside Ontario. And then they rated the proposals, and then the actual sites were chosen based on diversity of location, the type of institution, and their target population. So we have one sort of tertiary care center in Ottawa. We have Health Sciences North in Sudbury, trying to get some of the northern population and the difficulties of distances and travel. And then we have Lake Ridge Health in Oshawa, which is a large urban but also rural area. And importantly, we've wanted to make sure we reached out to some of the highest risk groups and our First Nations, Inuit and Métis population. The smoking rates in some of those communities is 80%. And they have very high rates of lung cancer. And so we wanted to make sure that we provided equity and access to these programs. So Ottawa is reaching out to Cornwall, where there's a First Nations community. Lake Ridge has close by First Nations, and of course Health Sciences North has First Nations as well, and they're all part of their programs. The pilot site requirements are that they have to embed smoking cessation and have an on-site lung smoking or smoking cessation program. They will have a navigator who will actually assess the individual's eligibility for the screening program based on that Tamamagi risk prediction model. The navigator will also be trained in smoking cessation counseling. So they won't do all the smoking cessation counseling, but they'll initiate it. So at the first contact, if the individual is a smoker, they will start down that pathway. We have developed a management algorithm for the little nodules that we're going to find, and we've adopted an American College of Radiology model called LungRads. We wanted to have a seamless link with the lung DAP. So if you have a nodule found that looks like lung cancer, we want to make sure that you are streamlined into the next step so that there's not a gap between finding that thing that's suspicious and figuring out is it cancer and treating it. I mentioned that we want to recruit the hard-to-reach, high-risk populations. There is legislation in Ontario anyway that to have ionizing radiation, so a CT scan, you have to be referred by a physician. So some people don't have primary care physicians, and we don't want them to be denied screening if they're eligible. So the pilot sites are going to maintain a roster, a list of primary care physicians who are willing to take on unattached patients. So if, for example, an individual self-refers to the program and they're eligible and they don't have a primary care physician, the navigator will contact the primary care roster and get that individual a primary care doctor who will then refer them to the program. And I mentioned they would have to have a level 1 thoracic surgery center and on-site smoking cessation. One thing about the primary care, you know, there are lots of individuals who are looked after by nurse practitioners. There is a family doctor usually attached to those primary care practices. But surprisingly to me, the nurse practitioners are not allowed to refer to this program. So we're working with the Ontario College of Nursing to try to fix that, but we haven't fixed it yet. This is our screening pathway, and I'm going to show you it in a little more detail. So here we are over here, recruitment and risk triage. So, you know, we're going to reach out to the communities, and I'll show you some of our strategies for that. We're going to reach out to primary care and have them help to recruit. And there are going to be a couple of guidelines for like who should you send for assessment. And it's going to be age 55 to 74 and at least 20 years of smoking. And the reason we've chosen those numbers is because from 50 to 55, and for those of you who are under that 55 number, you're going to say, well, what about me? But we found that most of the individuals between 50 and 55 didn't have lung cancer, and we were going to be screening people that really weren't at risk. Similarly, we know that if you've smoked for at least 20 years, you're going to make the cutoff in terms of the smoking criteria. Then the individual will come for an individual risk assessment, which would be done by our navigator. And if they are eligible, it will be discussed with them what the scan is about, what the test is about, what's involved with follow-up, what are the risks, that sort of thing. If they're ineligible, obviously they're ineligible, but if they are ineligible and a smoker, they will be linked to a cessation program. So even if they're not eligible for the program for screening, they're a smoker, we're going to try and help them stop smoking. And of course, if they're eligible and they're a smoker, we're going to link them with cessation. They're then going to have their scan, and the scan basically will have 3 results. So it could be a negative scan, a positive scan, or there could be incidental findings. So we know that on the CTs nowadays we find all sorts of things that aren't lung cancer, but they can be really important. And so those findings will be communicated back to the primary care doctor or the referring doctor or both. And it will be both a hard copy, a paper copy, as well as a phone call from the navigator saying, hey, your patient has whatever, and we're sending you the results, and the radiologists have recommended the next step. Because sometimes the primary care doctor doesn't know what the next step is. So, is it another test? Is it another referral? Whatnot. The negative scans, and those will be the ones that are categorized as LungRADS 1 or 2, and I'll show you what that means. They'll come back in a year for their next screen. The positive scans will be either LungRADS 3 or 4, A, B, or X. The ones that are 3s are probably benign, and so we're going to bring them back a little earlier for a follow-up scan in 6 months. The 4s we're worried about. So what happens to the 4s? The 4s are going to go to the diagnostic assessment program because that's why it's there, to evaluate people who have a suspicion of lung cancer. And so they may have additional tests, they may have a biopsy, whatnot. If they have cancer, of course, they're going to go on and get their staging workup and their treatment. And if they don't have cancer, they're going to come back to screening. Now, most of our diagnostic assessment programs have a thoracic surgeon attached to them. Some of them are run by respirologists, but some clinician is going to evaluate that individual, look at the scan and say, we're worried about this one, we're not worried about this one. And so we know that some of these are not cancer, and we don't need to go off and biopsy them, but we did not feel comfortable just leaving that to the radiologist to decide. So the actual LungRADS score in the US, the LungRADS 3, are just brought back for another scan in 3 months. And we didn't think that was okay. We thought that that was worrisome enough that somebody should lay eyes on the individual and have a conversation about the scan. So our recruitment objectives, we want to recruit potentially eligible individuals through both provider-led and community-led engagement. We want to support equitable access to everyone. So we're going to have some targeted recruitment strategies for some of our hard-to-reach individuals. And then we're going to be monitoring how this is working out. And if it's successful, then we'll roll it out across the province. So our recruitment strategy, we have community stakeholders, public advisors on our panel. The Canadian Cancer Society, the Ontario Lung Association have agreed to help us. Local pilot sites and their local community stakeholders are engaged with this, and then we're developing recruitment materials that everybody can use. The nodule management. So we know that with low-dose CT, 20% of individuals who come for one of these scans are going to have something found. Most of them, 90%, are not cancer. 90% of them are benign. And we don't want those people having operations or biopsies. We want to make sure that we follow them carefully, but we don't necessarily perform invasive procedures. Overall, the rate of invasive procedure is about 1 to 4%, so not too many. Harms from screening, risk of death, not likely, but it has happened. Complications from biopsy or surgery. And in the NLST, there were deaths. There were 8 deaths in the CT arm and 5 in the chest X-ray arm. So you're going to say, well, how did you die from a CT scan? Well, of course, they didn't die from the CT scan. They died from the biopsy, or they died from surgery, or they died from some other complication. But, I as a surgeon think, it's a CT scan, what harm could there be? But we do have to be cognizant that we don't want to do unnecessary testing on people who don't need it. We also know that the CT picks up 4 times as many benign lesions as the chest X-ray. What is LUNGRADS? LUNGRADS is a standardized reporting system for these nodules, and it recommends the management of the nodules, and it was developed by the American College of Radiology. And we decided to use this because it's commonly used, it's accepted, and it was adapted for use in Ontario. We had a Canadian version, LURADS, and our radiology committee, and this wasn't me, we have a diagnostic imaging program who we called upon to help us with this. They decided to use the LUNGRADS. Here's our reporting template. So this is the kind of thing this is what the individual is going to get at the end of the day before they go home. They're going to get a summary of the impression. They're going to get a classification about what their nodule is, and we're going to rate the most worrisome nodule. But if individuals have multiple nodules, they'll get a score for each nodule up to 10. So here we are. You need an additional lung cancer screening CT images or comparison with prior CT. So that's a LUNGRADS 0. That means the radiologist isn't sure. They want to look at some more images. You have a LUNGRADS 1, come back in a year. LUNGRADS 2, come back in a year. LUNGRADS 3, come back in 6 months. LUNGRADS 4A, B, 4X, you're going to go and have further testing at the lung DAP. And then if there's incidental findings, that'll be recorded. Or if they have a history of previous cancer, that'll be recorded. And why are we using this? Well, we know that if you have a LUNGRADS 1, the risk of lung cancer is less than 1%. Similarly, LUNGRADS 2, less than 1%. 3, it starts to go up, 1 to 2%. So those people are going to come back in 6 months. So the 4B, 4X, 4A will be sent to LUNGRADS, lung DAP. The 4A nodules are actually thought to not likely to be cancer, but their risk is up to 15%. So we were not happy with that individual not going and seeing somebody about further investigation. The 4Bs are the definitely suspicious ones, and the 4Xs are maybe not so suspicious, but the individual has other factors that make us worried, like their family history of lung cancer, for example. So those individuals are all going to go and have a proper assessment. In summary, I think lung cancer screening provides an opportunity to reduce lung cancer mortality in Ontario and elsewhere when it's rolled out. We want to screen those individuals who are at increased risk for cancer, at higher risk. And again, as I said, this does not deal with the question of the lifelong non-smoker who gets lung cancer. We're going to need a different strategy for those folks. We think it's important that we have an organized approach. It's not just about a CT scan. We have hospitals that just want to start screening and they're just going to do a CT scan and send the results to the family doctor. The family doctor may or may not know what to do with that. So we think it's really important that there's a process and it's organized and people get appropriate follow-up and aren't lost. Lung cancer screening is a team sport. We need the individual to come. We need the family doctors to encourage their patients to come. We need the navigator to help us. We need diagnostic imaging to be on board, and so we're going to have a radiology quality assurance program across the province, making sure that the radiologists reading these scans all call, a 3, a 3, and a 4, a 4, making sure that the technology is the same. The CT scan done in Lakeridge is the same as the CT scan done in Ottawa. I think communication is key. We want to manage the individual. I've said patient, but they're not patients yet. They're screening individuals. We want to manage their anxiety. Like on our committee, we have these public advisors. They're all smokers, and they're all like, I don't think I'm going to come for screening. You know what? They don't want to know. They're afraid. We also want to manage their anxiety when they get that report that says they've got a little nodule and it's a lung RADS too, and they're going, well, you know, we want to reassure them that we know that those nodules are not likely to be cancer, and but that we're going to follow up and make sure that we keep a close eye on them. So again, the plan is for them to get that little sheet of paper. They're going to know when they're going to come back. The navigator will explain what a lung RADS 1 is or 2 or whatnot. They're going to have that information when they go home. So they're going to go home with that information. They're not going to be waiting for a letter 2 weeks later and a follow-up image and so on. And importantly, smoking cessation is a key component. And our smoking cessation group at Cancer Care Ontario has been advising us on what works and what doesn't work. And so they are a key component of our program. Thank you.